Johnny Payne is a 78-year-old male presenting today with 2 days history of abdominal pain. He states that the pain began about 2 days ago when he was sleeping and it woke him up from his sleep. He states that he's never had a pain like this before and it's getting worse every day. He describes the pain as being in the left lower quadrant. It is sharp, intense, constant, does not radiate, and rates it a 9 out of 10 in severity. Walking and touching the area makes the pain worse. Sitting still or not moving makes the pain better. In his social history, we find that he eats 3 meals a day. It contains mostly a lot of nuts and grains. He walks every day and he drinks a cup of coffee each morning. He does not smoke, he does not drink, and he does not do drugs. His past medical history and his family history are non-contributory. Upon review of systems, we find that he thinks he has a fever. He has no chills or tiredness. In his GI system, we find that he has nausea all the time. He has loose stools sometimes. He vomited once after the pain started. The vomit had no blood, and there is no dark or tarry stools. In his GU system, we find that he is not sexually active since his wife passed away. He has no dysuria, frequency, or urgency. In his physical exam findings, we find that his blood pressure is 200/105. His heart rate is 102. His respiration rate is 22, and his temperature is 102.9. In general, he is a well-groomed, well-nourished male who is alert but is in distress due to the pain. His skin is warm and dry. The turgor is brisk. His nails are without pallor, cyanosis, and clubbing, and the capillary refill is less than 2 seconds. In his lung exam, it is clear to auscultation in all fields. In his cardiac exam, he has an increased regular rate and rhythm. S1 and S2 are heard, and there are no murmurs present. In his abdominal exam, there are no lesions, pulsations, or hernias. In the left lower quadrant, we find decreased bowel sounds, tympany, a small palpable mass, and tenderness to palpation on light and deep palpation. There is no rebound tenderness noted. The kidneys are palpable. The spleen and liver are without inflammation. There is no hepatomegaly or splenomegaly. In the digital rectal exam, we find that there is no cold blood and the rectum is patent. There is no CVA tenderness and the bladder is not distended. When testing for appendicitis, he is negative for the McBurney's point, Rovsing sign, obturator sign, and Soa sign. A differential diagnosis includes acute diverticulitis as our primary diagnosis due to the left lower quadrant pain, the change in bowel habits. Next could be diverticulosis due to the current presentation, a change in bowel habits, abdominal pain. Could be constipation due to change in bowel habits. It could be colorectal carcinoma due to the small palpable mass, or it could be atypical appendicitis due to the pain in the lower left quadrant. Our labs show a white blood cell count of 12,000. CT of the abdomen shows positive inflamed diverticulum. X-ray of the abdomen shows normal stool present. CMP is normal and fecal col is negative for blood. So my plan is to admit the patient, put him on an MPO diet, start IV fluids. We're going to give him some antibiotics that will consist of cefoxitin IV and metronidazole. We're going to do some patient education and increase dietary fiber and decreasing dietary fat. And we're going to do a consult to surgery and referral to pain management.